Good morning. Thank you all for being here and appreciate CEDBR's support of this conference. So everybody's familiar with what's going on right now with the shutdown, exceeding our budget authority that's been approved by Congress. We have the debt ceiling issue that will be upon us here in the next couple weeks. All of the negotiation around this has come down to issues largely related to the ACA, the Affordable Care Act, or Obamacare. A couple specific issues. Originally, there was conversation of potentially defunding all of the ACA, or now the conversation has moved more towards a delay of certain key elements of that. The medical device tax is something that may have some bipartisan support for repealing a tax on medical devices that is included in the ACA. And there was some discussion, it sort of died down now, about some of the coverage for contraceptive services as a potential bargaining point as well. The Democrats' position on that has been, we had a presidential election, we had a Supreme Court decision, and the ACA is the law of the land, and we're not going to revisit that any more times. They're not going to negotiate on the debt ceiling. So we've really come to a real serious point with a lot of background to this issue that makes it even more concerning to those of us in the health policy world. This stuff going on this week is in the context of a situation where many economists believe that the rapid growth of health expenditures in the United States is the single most important trend in the United States post-World War II. Many public finance experts feel that controlling healthcare expenditures is the greatest fiscal policy challenge for our country. So that's all going on in the background. It's been going on for decades, and now we have this acute crisis. Healthcare is unique in its blend between federal and state control and governance. And we know what's going on in D.C. Let me just comment a little bit about Topeka and lots of other state capitals around the country. This shows the number of states that have single-party rule, one-party rule, where both the governor's office and both chambers of the legislature are controlled by a single party. As you can see, there are 37 states right now that have one-party rule. That's the highest it's ever been since the 50s. And you can see how much it's gone up just since the 80s and the 90s there. In 25 of those 37 states, the legislative branch has a supermajority that's veto-proof even. It's even more than what it might appear just with the 37. So it is a highly polarized time for discussions about lots of policy issues and health policy in particular. This map should look familiar, the Electoral College count following the last presidential election. I show that just to set some context for the next couple maps that I'm going to show. This map shows states that have opted to implement an insurance exchange. The reddish colored states, following the theme of the previous slide, are states that have opted not to establish state-based exchanges, but to have the federal government come in and run the insurance exchange. Now we're calling them marketplaces. The blue states are states that are running their own exchange. There are a couple states that are doing something a little bit different in the middle. Those are the green states there. In Kansas, which has not set up its own exchange, but on Tuesday of this week, the federal government opened a federal exchange. I'll talk about that quite a bit later on. But in Kansas, right now, there are about 370,000 people without health insurance. We've estimated that about 250,000 of that 370,000, about 250,000 of them would be eligible for subsidies in an exchange. That means their income is between certain levels where they may qualify for some financial assistance in buying insurance coverage. So that's we don't know how many of them would actually buy the insurance, but that's about how many would be eligible, at least based on their income. Another major policy issue that's in play right now is this issue of whether or not to expand Medicaid. The ACA, as originally written, expanded Medicaid across the country to everybody below 138% of the federal poverty level. Just to give you an example, for a family of 4, that's an income of $32,500. So all families of 4 that made less than $32,500 would be eligible for Medicaid coverage under the bill as originally written, the ACA. The Supreme Court last year ruled that the Medicaid expansion states could not be compelled to expand Medicaid, that it would be at state option whether or not they would expand the Medicaid program. Up to this point, Kansas has not expanded Medicaid, so the eligibility level will stay where it is right now, which for a family of 4 is at about $7,600 a year for a family of 4. So in Kansas right now, for an adult to get qualified for Medicaid, their family income has to be below about $7,600. If you're an adult that does not have children, you can't qualify at any income level unless you're disabled. So there, people between those dollar amounts could be eligible for Medicaid in states that take the option of expanding it. Again, another number, various estimates have been put out there, but the best estimate is that probably about 225,000 people in our state would be eligible for Medicaid coverage, fall in that income range for eligibility. So out of the 370,000, there would be roughly 225,000 that would be eligible for Medicaid. There would probably be some people that would switch from privately paid insurance into Medicaid too if they were eligible. It'd be a better financial deal for them. But that's the rough numbers. And again, Kansas is one of about 22 states that is not expanding Medicaid. The other 28 are expanding Medicaid, or at least leaning towards expanding Medicaid. So this Medicaid expansion issue is a very hot political and policy issue right now. The way that the ACA is written, the expansion would be covered for the first 3 years 100% by the federal government, and after that it would come down to 90% by the year 2020 and stay at 90%. Now there's a lot to be said about that. Being paid 100% by the federal government doesn't mean that it's free. Somebody's paying the taxes that are going to the feds that are then being used to provide that Medicaid expansion. And there's been some concern about whether the federal government, given the situation we've been talking about already this morning, whether they'll be able to honor the commitment to pay 90% of the cost of that in perpetuity for states that do choose to expand Medicaid. The administration has been very clear that states can make the decision to expand whenever they want to. They don't have to make it this year, and they can also change their mind and back out of that if they choose to, if the feds aren't able to meet their financial commitment. A very important piece that isn't talked about a lot is that even if states don't expand Medicaid as the ACA allows, there will be substantial cost to the states. And the reason is that as the exchanges open up, the marketplaces open up, there's a lot of advertising and promotion about insurance coverage. There's a penalty for individuals that don't have insurance. It's going to make people more aware of the issue of having insurance coverage, and many people that are currently eligible for Medicaid but not enrolled for various reasons are probably going to sign up. The Brownback administration commissioned a study to look at this, and they estimated that even without Medicaid expansion, if Kansas does not expand Medicaid, they estimate that about 40,000 additional people will become enrolled in Medicaid that are already eligible but just not enrolled, at a cost to the state of about $500 million over a 10-year period from 2014 to 2023. So even without the state opting to expand Medicaid, there will be increased Medicaid costs for the state, and that's true for any of the states that choose not to expand. If Kansas did expand the study according to the expand Medicaid according to the study that the Brownback administration did, the cost would be about $1.1 billion to the state over that 10-year period, and would cover again that about 226,000 people that I mentioned before. So not expanding Medicaid has financial implications for the state as well. One other aspect of expanding Medicaid, and I'm sure there's some hospital representatives here, you know, what's an expenditure to the state or to the federal government is a revenue to a hospital system. And the Kansas Hospital Association commissioned a study looking at what the total net effect of the Medicaid expansion could be to the state. And if you think of the state spending of about $1 billion over that 10-year period, they point out in their report that annual federal money coming into the state for Medicaid expansion would start off about $330 million a year and increase to over $500 million a year of additional federal funding coming into the state for healthcare services. And you look at the economic activity that generates, the jobs, employment, lots of things with additional tax revenue. You know, that money that comes in does have an economic impact on the state. So the hospitals have been saying, let's take the bigger view and look at not just how many dollars the state's going to put out directly for the services, but what's the benefit going to be overall. Their study predicts that over that period of time, there would be negligible cost to the state if you offset the direct Medicaid spending by some of this increased economic activity and tax revenue that can be generated. So lots of things to consider about whether or not this would be a good idea for Kansas or any particular state to undertake. I just want to run through a couple slides that talk a little bit about the conversation of repealing the ACA. There is a very powerful sentiment by a lot of people that the ACA needs to be undone. And I think what a lot of people, lay people, don't understand is that the ACA has been the law for 3 years and a lot has already gone into effect. And so I just want you to think a little bit about the complexity, the legislative and political complexities of stopping the implementation or undoing things that have already happened. This is just a list of the things that started in 2010. Children with pre-existing conditions could not be excluded from coverage. They have to be covered. I'm just going to hit a couple of the highlights. They began addressing lifetime and annual limits on insurance coverage. The Medicare prescription drug rebates for people that fall in that so-called donut hole for prescription drug costs on Medicare. And then young adults staying on their parents' plans until they're age 26. I don't talk at a meeting where I don't have a significant number of people that say their 26-year-old or they as a 25-year-old have been on their insurance plan of their parents as a result of this. In 2011, the Medicare prescription drug donut hole was addressed additionally through some drug discounts. There's this so-called 80-20 rule where health insurance plans have to pay out at least 80% of their premiums in healthcare services, and if not, they make rebates to the the policy holders. Lots of rebates have been sent to people in Kansas and around the country. And then I just want to mention the Centers for Medicare and Medicaid Innovation, which started operation in 2011, but a lot of the information that we need to really understand how to pay in a smart way for healthcare to get the kinds of outcomes that we want, we don't really have all the answers to that, and the ACA does try to put additional resources and funding into trying to provide answers to those, how to provide incentives that improve outcomes and don't ration care, don't limit people's ability to get services they need, how to make healthcare more cost effective. So that has begun. In 2012, some of those programs were initiated looking at ACOs and value-based purchasing, a thing called bundled payments. The people in the healthcare providers in the room will know what those terms mean, but it's basically trying to change the way that we pay for healthcare away from paying on a fee-for-service basis, pay a physician or a hospital for every service they provide, and instead pay them an amount of money for taking care of a population, a group of people, not paying on a per-service basis. And an important issue is, are there going to be enough healthcare providers to take care of the people that may gain access to the healthcare system for the first time, or at least less fettered access to the healthcare system? And how are we going to train and recruit and retain the providers, not just physicians, that need to be in the workforce? And the ACA does make some payment changes to try to motivate primary care physicians to participate. But the big issues are the ones that are starting this week and soon, and that has to do with the opening of the marketplaces, these insurance exchanges. They opened on Tuesday of this week. I'll talk a little bit more about some of the challenges with that. But in 2014, bigger changes are coming. Coverage cannot be denied anybody, not just children, starting in 2014 if you have a pre-existing condition, any kind of illness or disability. You can't base rates for insurance coverage on health status or pre-existing conditions. That's one of the main tools that's used now by insurance companies to try to maintain profitability and keep high health risk people out of the insurance pool. There are other pools that have been set up to take care of people with high risk, but it's the way that the health insurance system is operated, and it's a fundamental shift in the business model for them. The annual limits that started coming down in 2010 will be eliminated. Then another big one, the premium tax credits and the cost sharing reductions. Those are the federal assistance to help people buy insurance coverage on the exchange. I'm going to talk about that in a minute here. And then the small businesses, there's some tax credits for small businesses. I'm sure Bill will have some things to say about that. The Medicaid expansion we talked about, and then the individual mandate penalties kick in. If you don't have insurance coverage as an individual, with some exceptions, then you have to pay a penalty for being uninsured. They're trying to, the flip side of making sure anybody that wants insurance can get it, even if they're sick, the flip side of that is you've got to try to get as many people as you can into the insurance system to try to keep that system afloat, keep the risk pool stable. Not everything has gone swimmingly with implementing the ACA either. Here are some just highlights of things that have not gone as planned, originally envisioned in the ACA. The long-term care program that was very ambitious was abandoned back in 2011. There have been some delays related to the ability of small employers to buy insurance on the exchange and the number of plans that they'll be able to offer to the employees of theirs if they do sign up. The employer mandate, the penalty on employers of more than 50 employees to have to pay a penalty if they don't provide affordable, good quality insurance to their employees. That penalty has been delayed for 1 year. A lot of people don't realize that the ACA has out-of-pocket cost limits in it. And basically, that has to do with even if you have insurance, there are still costs that you're going to have that you have to pay on your own. And the ACA sets limits of about $6,200 for an individual, about $13,000 for a family, but there's been a delay of 1 year in implementing those out-of-cost limits. And then I just want to mention the sort of what's happened the last couple days. The performance of the exchanges could be interpreted a couple different ways. One side says, oh, the demand has been overwhelming and the systems are getting inundated with requests. The federal website had more than 6 million visits in the first several hours that it was open. The state of New York website had 3 million visits in the first several hours that it was open. But in reality, there are a lot of technical challenges with implementing a system that complex, and I think that a lot of people aren't too surprised we're seeing the kinds of delays and technical problems that we are. People are being quick to point out that you don't have to sign up for a plan and you don't have to pay a premium until the middle of December if you want your coverage to begin the 1st of January. That's the soonest that you can get coverage through the marketplaces. And you can enroll all the way up through the end of March of next year. So, you know, the technical issues that are happening right now presumably will lessen as the systems get off the ground. So I want to talk a little bit about the exchange here in Kansas. It's how many of you have tried to get on either any of the exchanges, the Kansas exchange or any of them? Has anyone tried to get on it? We've had lots of people trying to get on it, trying to see what information you can get, and it's been a challenge from a technical perspective. But we have a lot of information available about what is offered on the exchange, and let me just start here. There are two big questions about the exchanges. One is, how many plans are going to be offered? Are they going to be good enough to get people to actually want to sign up? And are the prices going to be affordable? Are people going to buy insurance on the marketplace? Well, in the Kansas marketplace, there are 72 health plans that are going to be offered, 65 for individuals and 7 for small businesses. There's an additional 8 of those are catastrophic plans, which are just for young people who may not want to buy more comprehensive coverage, but more high deductible catastrophic coverage. But you know, most people would say that that's a pretty reasonable number of choices for people to choose. You can see the different levels there, the bronze, silver, gold, platinum. Just in the simplest way possible, the bronze plans they all cover about the same services. They all have a very comprehensive set of benefits available for people that buy the plans. The bronze plans, the premiums are a little bit cheaper, but you pay more along the way for co-insurance, deductibles, that sort of thing. So lower upfront costs in terms of premiums, but some higher cost sharing if you have a lot of medical expenses during the year. The platinum plans have more expensive premiums up front, but they're more generous in terms of the share of the health costs that they pay along the way. And the catastrophic plans do include a preventive visit every year and 3 primary care visits, but then after that, there's a big gap of no coverage and you pay out of pocket until you get to your catastrophic coverage levels. I have maps that we've put out at the tables in the back of the room because I can imagine that you'll have a hard time seeing this from back there. But these are the actual premiums that are being offered on the Kansas marketplace effective Tuesday of this week. There's about a 20% variation by these 7 rating areas. They set up 7 rating areas in the state, and about a 20% variation from the lowest cost area to the highest cost area. And the health plans were allowed to do that based on things like historical medical expenditures, the cost of doing business and labor in those regions. Within each region, there's actually very little variation. The health plans that bid in the market bid very close premium prices within each region. I should have said on the previous slide, there are 4 insurance companies offering those 72 plans in Kansas. Blue Cross Blue Shield of Kansas City, Blue Cross Blue Shield of Kansas, and Coventry actually has 2 separate companies offering insurance in the marketplace. There are private insurance companies offering private insurance plans, and these are the prices that they have put out. You'll see the way that this map is set up is your premium obviously depends on how many people are in your family, how old the people are that are covered in that family, and where you live. And smoking status. You can also adjust up to 1.5 times the premium for a smoker compared to a non-smoker. These are assuming non-smokers. But these premiums cannot be adjusted based on the health status of the people signing up to be covered. I'm going to skip ahead to the next slide. Let's just focus on the young individual. A lot of information on here, but if you're a 28-year-old individual in Kansas and you live in one of those rating areas, Wichita is in rating area 6, so let's pick that one. The benchmark plan, which is sort of a middle-of-the-road plan, for the technical people, it's the second lowest cost silver plan that's offered in a county, but it's a middle-of-the-road sort of a plan in terms of the covered benefits and the cost sharing. If you're 28 years old, you can buy that policy for between $190 and $196. If you decide you want to buy a little bit less generous plan, you could buy a bronze plan for $126. If you want the best insurance possible, you may anticipate a lot of medical costs. You could sign up for the highest cost platinum plan available at $300 a month. And if you decide you just want that minimal catastrophic coverage, your premium would be about $84 a month. So that's just an example for a 28-year-old individual. The response I've seen from most people when they see these prices is, wow, the prices are better than I thought. I mean, any of you that have bought insurance in the small group market or the individual market, these don't look all that bad. You have to be careful comparing the kinds of insurance that you may have now through a small employer, you may have bought on your own. They may not be exactly comparable, but I would say most people have concluded that 72 plans and 65 for individuals to choose from, and the sorts of rates we're talking about are not off the chart, and there was some concern or hope, depending on your view, that they might have been. Let me go to one more important concept. We talked about the Medicaid expansion and states that have opted to expand Medicaid or not. This slide takes as an example a 63-year-old couple living in Area 2 up around Topeka, and what the cost would be. Their premium for that benchmark plan, that middle-of-the-road plan, is $1,092 a month. Depending on their income, they are eligible for a tax credit through the marketplace. If they make less than 100% of the poverty level, which is $15,500 for a family of 2, then they don't get any tax credit because the ACA was set up in a way that they assumed everybody in that income level would be getting Medicaid expansion. So the current law is that in Kansas and other states that have not expanded Medicaid, if you're under 100% of the poverty level, you are not eligible for Medicaid, and you are not eligible for the premium tax credit. So that family with an income of $15,000 would pay the full price of the premium themselves. A similar family that made $1,500 more at $17,000 would be eligible for a very generous benefit, tax credit. So their cost would be about $28 a month. And then it goes up as your income. That premium tax credit is a sliding scale based on your income level. And once you hit 4 times the poverty level, which in this case is $62,000, then you're not eligible at all for a tax credit again. So I could spend more time going through lots of different rates and scenarios, families of 4, other individuals, but you get an idea of the kind of policies and the premiums and the cost sharing that will be available in the marketplace in Kansas. I want to move on to go back to Medicaid to some extent. You know, the insurance exchanges and Medicaid expansion and the Medicaid program are big issues in all states. And in Kansas, the Brownback administration has been very ambitious in setting up a reform of the Medicaid program that had a lot of critics to start out. And I think that it's gone better than most people would have anticipated. And there's a reason that the Brownback administration is concerned about the Medicaid program and wanting to reform it. And this slide shows state general fund spending. The top line is for K-12 education, which is the biggest part of state spending, and it has leveled off and even come down a little bit in the last couple of years. The next line there, the blue line, is Medicaid spending, and you can see that that line does not look like the other lines in this chart. Medicaid spending is going up, and states do need to do something to address Medicaid costs at the state level. And the CanCare Reform Initiative of the Brownback administration is an attempt to try to get at that issue. I have 2 more numbers to show you about the costs and sort of where we're headed with this. This is the most recent, it's over a year old, July of 2012, from the Congressional Budget Office, looking at the expected impact on the federal budget of the implementation of the ACA. I didn't make up the numbers. There are a lot of people that don't believe the numbers, but you can see that the costs to the Treasury are about $1.7 trillion over that period through 2022. The biggest bulk of that is for those tax credit insurance subsidies that I talked about a little bit ago. But there are also benefits to the Treasury built into the ACA, reductions in Medicare spending, the penalties that individuals and employers would pay. There's an increased tax on high-wage earners that it kicks in at $200,000 for an individual, $250,000 for couples, 0.9% Medicare tax. And then there's the device tax that I mentioned before. So the estimate from CBO at the time is that the net effect would actually be a reduction of about $100 billion on federal budget. Again, there are a lot of assumptions that went into that. I wouldn't be willing to stand up and argue with every one of them, but there haven't been a lot of projections that have predicted the kinds of impact on the deficit and the budget that we've heard. Last slide is this one, which looks at, you've seen a lot of things about gross domestic product. This looks at the rate of growth in the gross domestic product. That's the blue line at the bottom. The green line is the growth rate for national health expenditures. We're in a bit of a slowdown period right now, possibly because of the recession. Some people say maybe some of the early effect of the Obama administration initiatives. I think it's pretty early to attribute some of the flattening to that. But you can see the projections going forward. The green line that juts up there is the national health expenditure growth rate with the ACA as written right now. So you're going to have a lot of outlay for the subsidies, and you're going to see a big increase in the growth rate for the next couple years, and then it kind of flattens out. The red line there is the line of what would have happened without the ACA. So you can see the growth rate is less in the next couple years, but then it basically catches up and hangs with the projections for growth in health expenditures with the ACA. The thing that's concerning to economists and a lot of policymakers is the gap on the right-hand side of that chart. The growth rate for healthcare under either scenario is substantially higher than the growth rate for the economy. And the prediction here, we spend about 17.9% of our GDP on healthcare right now. By 2022, under these assumptions, it would be about 20% of our GDP going to health. And people wonder how sustainable or how efficient that is in terms of a health system. So we have big challenges ahead of us in the health sector. I think most people would agree that we have an amazing healthcare system that provides incredibly miraculous outcomes and results, incredible innovation compared to other countries of the world. But we also have a system that's very complex and inefficient and unfair in many ways, and costing businesses, costing the federal government, and costing families in our country more and more of their budget. And people tend to agree we need to do something. I would gauge by the conversation going on in DC this week, we haven't come to an agreement quite yet on exactly what that should be, but we probably all agree we need to do something. Thank you very much.